All right, hello everybody. My name is Chris Pallas, cardiologist at MCG, and this is the EKG video. This is actually part 2. If you missed part 1, there's a link below that you'll be able to pick it up on and look at it. Basically what it is, for those who might just be joining us, and to remind everybody else, this is a cursory view, an overview, if you will, of reading, of a method of reading EKGs. And the whole purpose is just to ensure completeness, to rapidly identify normal from abnormal. Then all our future sessions will be breaking down the differential. Every time we come up with an abnormality, how do we determine what the diagnosis is? So this slide is just an overview of the overall method, showing you steps. There are nine steps in this method. I made the point before that the beauty of this is doing it the same way every time, okay? Just thinking of pilots like an aircraft, checking that you have checklists. You want to make sure everything is good. So I have 9 steps here, and the important thing is to do it the same way every time. Now, I made the point that this is my order. You can do it in any order you want, with one exception. I highly recommend, and actually would say you were foolish if you didn't do it this way. You need to do steps 1 through 4 the way I got them in order, okay? Because they give you the foundation for the rest of this. After 4, you can do whatever order you want, but just do it the same way. Keep the same order. That way you know you're complete. So this is the order that I do it in. Now, we have finished looking at the rhythm strip, making sure the quality of the EKG is good, looking at calibration, lead placement, and determining rhythm and conduction. Okay, the concept is we basically determined how things flowing smoothly and normally from the impulse generation in the sinus node through the AV node into the ventricles. Okay, so that leaves us now at number 5, okay, where we're going to measure the QT and the QTC. I want to explain why I put the QT as number 5, okay? So if you look at these, this is really, I look at everything, it's a matter of triage. You know, I'm looking at the rhythm strip very first to make sure I'm not going to have a very slow or very fast rhythm, potentially like threatening the patient in any way. And then I make sure that the quality of the EKG is good. And then when I know rhythm, I want to make sure I have a physiologic rhythm that is normal, or identify an abnormal rhythm if I need to. Likewise, step number 5 is measuring the QT. Now, the reason I do that is because QT prolongation it can be dangerous. It can lead to arrhythmias like VTAC or VFib. You might have heard of a long QT syndrome, which is a congenital, what we call a channelopathy. You're born with an abnormality in some of the channels, and you end up with a long QT and risk for sudden cardiac death. But more importantly for us, actually, is iatrogenic QT prolongation through medicines that are prescribed in the hospital. Now, let's just think about, let's say, our hospital, the Medical College of Georgia, with all the beds that we have on any particular day. How many people in that hospital are getting antibiotics or on antidepressants? Some of the most common prescriptions written in the world, okay, all of which can prolong a QT and therefore potentially threaten a patient from VTAC or VFib arrest. So measuring the QT becomes important, okay? Now, I'd like just to make a point here. When you get an EKG, and you see it on your screen or it's printed, the EKG comes with measurements made. Here we see the ventricular rate. They're counting the QRSs. They measure the PR interval, the beginning of the PR to the beginning of the QRS. Then they measure the QRS duration, that is the beginning to the end of the QRS. And then they measure the QT. The QT is the beginning of the QRS, okay, to the end of the T wave. Axis is also measured, etc. The computer is good at measuring rate. It's good at measuring the PR interval. So when I look at these, I tend to believe it. Although, as you know, I don't trust my eyes, so I'm always measuring everything myself with calipers. The QRS duration, it's not totally great at. So I'll actually measure everything manually myself. But the QT, if you get lazy and you don't measure those manually, for God's sake, my message to you is the one thing you need to measure manually on everybody is the QT interval, because the computer cannot do it. If you look at any day in the heart station where we're reading EKGs for the whole medical center, on any given day, I will promise you 35 to 40% of the EKGs, as screened and read by the computer, are reported to have a long QT syndrome, when in fact, when we manually measure it, that's not true. So obviously there's a problem with the program worldwide in these computers being able to measure a QT interval. All right. So that having been said, what about the QT interval? I use the maximum slope method. All right. 3 steps here. 1, 2, 3. Okay. 1, you draw, and this takes a pen. Ta-da. And then it takes some sort of straight edge. Okay. You can use a card. And what you do is, I'm going to illustrate it with my beautiful yellow card here. So I draw a horizontal line. This is called my baseline, step number 1, okay? Now, what is the baseline? The baseline, now this is different than the baseline we're gonna talk about when we talk about ischemia and ST segment elevation. This baseline is gonna be the distance between the T and the P, okay? And what that would look like on the EKG, okay, that would be my baseline, would be the TP interval. TP interval. So I would just take, here, let's look here. I would take that, it slopes down a little bit, and I would draw my baseline like there across to there, okay? That's what it looks like here. Number 2, maximum slope. Maximum slope refers to the slope of the T wave. So I take my card, and you can use anything. I mean, most in the hospital, most of the time I use ID badges. And then you just take it and you put it, you lay it down on the descending limb of the T wave, and you draw it until it intersects your horizontal line. All right? So real time, that would look like, let's say here, I draw my TP, and then I would take my card, I would lay it parallel on the descending slope of the T wave and draw that down where they would intersect. There is normally, if you look at this EKG, P, QRS, T wave, there's a thing called a U wave. The U wave oftentimes is not visible. It's visible at slower heart rates, and on a regular heart rate in a normal EKG, it's visible often in V4 or V5. So there, P, QRS, T, that little thing's a U. That's a P. Okay. The computer, now this is important. Notice that we're not drawing, the QT is not from here to there. The QT is here to where that line intersects at the end of the T. The computer gets goofed up calling everything long QT because oftentimes it confuses this T wave, this U wave, as being part of the T. So here, this illustrates how we do it. Here, while we draw maximum slope, notice I'm on the downslope. I'm excluding the U wave. The computer more than likely would include that. So notice how much the QT gets so much longer. Okay. The only time we might include the U wave is if it's very tall. Okay, so notice here we measure the QT. We go horizontal, maximum slope, where they intersect. That's the QT interval. Then I would take my calipers, go from the beginning of that to where they intersect. That's my QT interval. Likewise here, same thing. We would exclude the U wave. But here, because it's tall, it's almost as tall as the T, we include it, and so it would go out to here. Okay, that's just how to measure it. All right. So more detail on how to do it. Maximum slope method. We're interested on drawing a horizontal line, maximum slope of the T, and finding where those two lines intersect, and we have to decide what to do about the U wave. Okay? So what we do is, we're going to, knowing that's our general thing, we're going to look at V4, 5, or 6, because that's where you are more likely to see a U wave. Here's a U wave. Okay, you pick the one whichever looks longest, and you do this method for 5 or 6 beats. Okay, coming up with a QT interval as you measure with your calipers. Okay, then you average. A U wave, okay, if this U wave is greater than 50% of the T wave, you include it. Okay, 50% amplitude. See, this is less than 50%. That is less than 50% of that height. This is more, so you would include it. Okay? So, how to measure? Once again, we're going to reinforce this the same way. Okay? I draw my baseline between the U and the P. I draw it all the way across. Then I take my straight edge, maximum slope of the T. Okay? Where those two lines intersect, that becomes my QT, as I've labeled here. Okay? Notice we didn't include this. It's less than 50% of the height of the T wave. Okay? So, notice, too, if I use my eye, this is going to illustrate another point, how I don't trust my eye. Let's look at this complex right here. If you were going to ask me to eyeball this, not use calipers, not use this method, and you were going to ask me, and I'll ask you, and I'll guarantee it, 75% of the people looking at this will say the same thing. If you ask me, where does the T wave end? I would say it would end right there, where it goes all the way to baseline. But it doesn't. It ends, that's for measuring the QT, it ends right there. So notice we exclude how many milliseconds. So now we see how the QT is typically, as we measure it, is typically much shorter than what the computer is going to measure for various reasons. So anyway, this is how you do it with upright T. If the T wave is inverted, well, you just invert what you do. You measure the ascending slope. That we're measuring the back end of the T wave on both occasions. This one is pointing down because the T wave is up, and this one's pointing up because the T wave is down. Okay? And then we know how to make a count for the U wave. Okay, if it's less than 50% of that height, which this is, that looks like about 30%, you don't include it, and you include it if it's greater than 50%. Okay. So, after we measure, what do we do with the QT interval, okay? So if we look back at our EKG,
one more slide back. One more past that.
if we look at our EKG, we see QTC. What is QTC? Okay, so the QT, we're measuring a QT. What the hell is a QTC? It's a corrected QT for heart rate. The QT gets longer at slow heart rates normally, and normally gets shorter with fast heart rates. So you have to correct it for heart rate. Notice how it differs here. The computer measures 371, but when you correct it for heart rate, it's 406. You know what I think about those numbers, right? We'd have to manually make sure that's correct. So what do we do? What's this mean? So 3 correction formulas, okay? I hope you all have MD Calc on your phones and your devices. Go to MD Calc, okay, to do the corrected QTC, okay? You'll see 3 names will come up: Bazette, Fredericia, and Framingham, all right? I have never personally ever in my whole life used Framingham. I typically use Bazette, but how do we decide which one to use, okay? Now, remember, all you're going to do is put in a value in your device. MD Calc will do this calculation for you. Bazette was originally developed in 1920. It's the most commonly used, but it's only really valid at normal heart rates. Normal heart rates being 60 to 100 beats per minute. So if I'm really tacky or really Brady, I'm not going to use a Bazette, but I'm going to use Friedrichia. Okay? That's the bottom line. And again, you just go to MD Calc. All right, so here you go. All right. I wanted to get down to the tabloid side of medicine. You're going to have people tell you that, well, you can eyeball a QT without using calipers, without measuring anything. You can eyeball it by just looking at the QT interval as compared to the RR. And if that is less than half of that distance, it would be, quote, normal, okay? If it was greater than that, it would be abnormal, okay? But notice how at extremes, really tacky, really Brady, what apparently would eyeball to be normal, that being the QT, the eyeballing the beginning of the Q to the end of the T, is half of the RR, you would say that would be normal. However, when you calculate this, the QTC is 512 milliseconds, which is high risk, as we'll see, for VTAC and sudden cardiac death, and this apparently eyeballed to be normal. Don't ever fall for that. Don't ever believe it. Use your calipers, folks, okay? So they're normals. Then you can compare what you come up with, your corrected QTC. All right, prolonged QTCs, you see vary by gender, okay, and extreme age, okay. Anything over 500 puts you at risk, high risk for immediate electrical problems like VTAC, VFib, okay. In one nutshell, this is it: 440 in men, 460 in women, 500 torsade de pointe, that's polymorphic VTAC, okay, and there is such a thing as a QTC that is too small, too narrow.
Is there a clinical implication of too short of a QTC?
The same, and we will get to that. There is. It again represents a channelopathy. We'll be talking about Axis, okay. Axis, usually people roll their eyes when you get to Axis, and I think it's totally overrated. I do believe it's important, but you have to remember, you're really just looking for a normal area. In other words, the concept is, we're back to what we did in the first section. If you sum up all these millions of vectors, basically depolarization, electrical activation of the heart starts up here and depolarizes the atria and goes to the ventricles. So if you summed up all the vectors, it would be going from top to bottom. It'd be going from the base of the heart to the apex of the heart. One big vector, okay? And remember, the concept that we had is that the EKG is like satellites, or like here we see cameras positioned over certain areas, certain surfaces of the heart looking at a certain area. The limb leads 2, 3, and F are the cameras looking at the inferior wall. L and 1 looking at the lateral wall. AVR is this is on the right shoulder, okay? Here we see AVR, okay? There's positive end of AVR, right shoulder, okay? So we just basically want to know, is this vector pointing in an appropriate way? And what we see here is that normal extends from, some people say this is a more liberal interpretation, from just past 90 degrees to just under 30 degrees. Probably better to say it's at 90 degrees to about 30 degrees. Okay, so you want to make sure that you're pointing, remember the concept of this is like America, you know, you want to make sure the vector's pointing to the southeast, away from the northwest, so you want to make sure it's here. Nobody cares if it's 60 degrees or 30 degrees. No one's ever going to ask you, was it 32 degrees or 30 degrees? Was it 60 degrees or was it 82 degrees? All they want to know is, are you in this area between 90 and 30? That is AVF and AVL being your boundaries, okay? And so how are we going to determine what's normal? We're going to use the rules of electrocardiography that a depolarization wave, as we define by the vector that we're talking about of depolarization, goes towards a lead, that is towards these leads. You would get a positive complex. Away from them, let's say away from AVR, you would get a negative complex, and at 90 degrees, you would get a biphasic complex. So we would say here in limb lead 2, you'd get what kind of complex from this? Biphasic. In limb lead 2, you would get what? You would get a positive complex. In AVR, you would get a negative complex. That's how we're going to figure out axis. Okay? So then what would define, how do we use that, in practical terms? If I want to be between 90 and minus 30, that is between AVF and L, I would look for positive complexes, let's say in AVF or 1, okay, or 2. And the more aligned that vector is with a particular lead, the higher the R wave is. Okay, so that's how I can figure it out. So let's look at this EKG. In this EKG, I look at my QRS and I see I'm upright in 2, 3, and F. That means my vector is going down this way towards those leads. I'm negative in AVL, so that means that's the axis of AVL, and I'm going away from it, okay? So I'm down like this. And these look about equal, okay? So I'm almost at 90 degrees, all right? I'm basically splitting the difference. That's how we would use that. This EKG, shows the opposite. It shows negative complexes in 3 and F. That is, I'm going away from 3 and F, so I must be going up this way towards AVL and 1. Indeed, AVL and 1 are both positive, and of the two, A1 is more positive. Okay, see that? I'll use my calipers. More positive, both are positive. This is more positive because it's got a taller R. So I'm really lined up more on 1. Okay, and indeed the QRS axis measured here is like minus 12 degrees, almost horizontal. Next, we're going to look at precordial leads. Okay, I want to screen the precordial leads real quick for what's called anterior progression. And here's the notion. Again, here we envision our leads versus underlying cardiac structure. V1, this is sternum, spine. V1 is on the right sternal border, V2, the left sternal border. Underlying cardiac structure, there's septum, right ventricle, left ventricle. As we go across from V1 to V6, we go over more and more of the left ventricle. So by the time we get to V4, notice that as we get over more of the ventricle, we finally get a positive R wave. See how that's more positive than that at V4? That's where that's called a transition zone. So I'm going to look for a positive, mainly positive QRS by the time I get to V4. There we go. We see it schematically there. This is easier for you to see. Here the QRS finally gets big as it goes over more of the left ventricle. Okay, transition zone. So I look at a normal EKG real quick. I only look at the precordial leads. V4, R ought to be bigger than the S wave. That's normal progression. Versus early transition. Here we see a positive complex at V2, all right? And that's early because it happens before V4, or it can be late transition. Here we see it never even gets mainly positive. So that's a late transition. There are many different reasons to have either of these, as you might envision. Let's see, what would make big complexes, let's say in V2? Well, anything that would make something point towards V2, let's say maybe a big RV. So that would give you big forces in V1 and V2. A late transition, what if you had a lot of scar here and couldn't generate a QRS? You might see late transition like that. It might be due to scar. Now we're going to talk about structure, which basically is going to focus on hypertrophy of the chambers. And most notably, we will start with LVH, okay? And so in our little schematic here, we'll be talking about the left ventricle here, here. This is the left ventricle, all right? And what we're gonna see, we're gonna be looking for hypertrophy or increased thickness of this chamber, all right? And we're seeing it here in different views. And so we remind ourselves about where our leads are looking at the ventricles. Okay, notice that V1 and V2 actually are a little bit more over the right ventricle. They're parasternal on the chest, okay? But as we go, and we discuss this with progression, as we go towards V4, we go over more and more of the left ventricle, generating more and more of a R wave. So the R waves are proportional, okay? Now let's talk about R waves. To look at standard EKG, we're talking about measuring this height, okay? This is, remember how we were always using our calipers, so that's the height of the R wave. That would be an S wave. This is the height of another R wave. So what kinds of things, and we discussed about standardization, calibration, and we checked that because if that's one large box wide, too tall, that tells us that these voltages are taken at face value. In other words, if I take my calipers and I determine that that's an 11 millimeter R wave, that calibration being normal tells me it is truly 11. If this was double the height, then on the EKG, that R wave would appear twice as big. Okay, so that's where we're going. So obviously we're measuring height of R waves. So we would have to know where to measure. Again, leads, again, as compared to underlying cardiac structure. So what could determine voltage? Okay, the height of this R wave. Well, anything that was between the leads and the heart could decrease voltage. That could be fluid, pericardial effusion, it could be pneumothorax, it could be fat. Right? Likewise, voltage can appear to be increased if you have a very skinny thorax and not much subcutaneous fat, etc. All right? And the other thing that's going to impact on voltage is not only is there anything between the leads and the heart, but the heart muscle itself. As the heart muscle gets thicker, there's more muscle to depolarize, and that means the R wave gets higher. So the R wave now must become very important for us to measure so we can determine is there LVH or not. Okay? Remember, these voltages, we're doing this in the context of something we've done earlier in the process, which is making sure that our standardization or calibration is okay. So this is what I like to do. Conceptually, you're going to notice when we look at criteria for LVH, there are many different criteria for LVH. I've listed 5. Okay, I've done this on purpose, and these are probably the best. And these are handpicked, and they're handpicked for a reason. You're going to notice that they look on both sides of the EKG. What do I mean by that? I mean, these are the precordial leads, V1 through V6. These are the limb leads, 1 through AVF. So I look at criteria that involve limb leads and precordial leads. Okay, I do that for a reason. It's because it's uncanny how many times, and I can't really explain why, but it's uncanny how many times you can see unbelievable evidence of LVH in the limb leads and not even see a lick, not even a trace of it in the precordial leads. And vice versa. Sometimes you can see raging LVH here, see nothing here. So you have to look at criteria that look at both sides of your 12 lead, okay? Now, this is one of the few things that we need to memorize. All right, so I'm not a big fan of memorization, but sometimes it's a necessary evil, right? So I would suggest either you put this on your device, okay, or keep a card in your pocket. If you have a clinical book, like handbook that you use, Merck manual, whatever, you keep these on you. And the more you use them, like everything else, you will remember them. They'll just become a part of you. So this is it. So I start with the simplest thing first. Now let's remember something here, that as soon as we meet criteria in one of these, we stop. You're done. You don't need 2 out of 3, 3 out of 4, 4 out of 5. All right. As soon as you hit one, you got LVH criteria. All right. So I believe on taking the easiest shot on goal. Take the shot, the easiest one you got, and the easiest one to remember is the R wave in AVL. Okay. So that would be here. Here we see AVL, okay, and we're going to take our calipers, okay, and we're going to measure the R wave from our baseline here to the top. And then we're going to count, is it 11 small boxes? And this is not. This is a normal looking AVL, not exhibiting hypertrophy. On the other hand, we see here the height of the R wave in AVL actually jumps out at us, and it's clearly 12, 13 millimeters, small boxes that I've counted. Okay, so you're done. This is LVH. Okay, voltage criteria for LVH. Now, this EKG shows other things. We're going to come back to this EKG because it shows many other features of LVH as well. But right now, we're just going to focus on voltage. Okay. So that having been said, we looked at R in AVL, 11 millimeters. If that doesn't get it, I'm going to stay with the plan. Since I've already measured AVL, I'm going to go to my second criteria. Again, I believe in doing things simply. I'm going to take AVL, which I've already measured, and I'm going to add it to the S wave in V3. The S wave, that's the R. Then the S wave is the negative component after the R wave. So I go to the baseline, I measure it where it comes up to the ST segment, take my calipers and measure it. So I take that number of small boxes that I'm going to count, and I add them to the number of small boxes that the R wave was tall in AVL. I'm going to add them. This is the only criteria, as you can see, that is not gender neutral. Men tend to have thicker ventricles than females, and so therefore we see that the criteria is 28 millimeters when you add the S wave in V3 and the R wave in AVL, greater than 28 millimeters in men and 20 millimeters in females. Okay, this you might see it referred to as a Cornell criteria. All right, so once we've done that, let's say we don't meet criteria there, then we're going to stay with the limb leads. Okay, now remember, we're saying the first criteria here, they're all about limb leads, and then it's the last two that look at the precordial leads. So the last criteria we're going to look at in the limb leads is we're going to add the R wave in 1 to the S wave in 3. We're going to add those together. And if they're greater than 25 millimeters, gender neutral, you have LVH criteria. Okay, so this is the way it swings for the limb leads in LVH. My eyes go here, then R wave here, plus S wave here. If that doesn't get it, then I go R wave and S wave. Boom, I go here, here, and here. Here, here, here. Okay, if I don't make that, then I have to move to the precordial leads. All right, so let's talk about the precordial leads. Okay, and this is actually very simple. This is quoted in most of the EKG books. You'll see Sokoloff-Lyon criteria, where you just go to V1, all right, and you add the S wave in V1, and then the biggest R wave you see in V5 or V6. Okay, so what that would look like with our LVH, we would add this, okay, to the that we see here. Now, how do we see what's going on here? Where does this R wave end? Well, if you look carefully, you can see that there's a double line here, all right? Meaning that the R wave has gone up and it's superimposed on the S wave from the lead before. So it ends right there. So we add this plus that, okay? And we get over 35 millimeters, all right?
I have a question.
Mm-hmm.
When you're looking at an EKG like this, I've seen some like this on the wards where there's massive LVH and the QRSs are just really interfering with each other. Is this a good time where you might want to redo the EKG or recalibrate it with these boxes to get it separate? Like if you cut the voltage standardization in half, can you do that?
That's a great question. You can do that, but you don't need to, because you can see your eye, you train your eye, just follow the line. For example, the S. Okay, you have a single intensity, okay? It's iso-dense, the same intensity all the way down, all the way down, all the way down. Then all of a sudden, it continues, and then it becomes hyperdense because it's superimposed. So wherever that double intensity ends is where the R wave ends. So you ought to be able to pick that out. So here, same thing. Let's follow it down, iso-dense, iso-dense. All of a sudden now, it's double dense because it's on the S wave, then it becomes iso-dense again. Where it stops, it's no longer superimposed. So I'll show you where that is. That's a good question though. And if you want to, this would be an opportunity to change calibration. All right. So that was Sokolov-Lyon. Lastly, we look for any R in V4, 5, or 6 to be over 26 millimeters. 4, 5, and 6. Here we see clearly, these are puny, all right? Versus LVH, where, again, iso-dense, 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 double density, and then it stops. And count how many large boxes that is. 1, 2, 3, 4, 5, 6, 7. It's a huge amount of voltage, okay? So those are the criteria. Again, that's voltage criteria. Now, let's just discuss something in general here. Let's look at this EKG. Let's, by comparison, let's start to train our eyes, okay? When we look at this EKG, we see everything looks nice and neat and discrete, right? Voltages look really reasonable versus, you know, the first thing you notice when you see this is what? You see tons of voltage, and you also notice what else? This to the eye appears narrow. The QRS appears quite narrow. You can double check it, and it is. And then all of a sudden, here, which this is, remember, LVH, notice how the QRS is wider. Okay, that's because of LVH. So muscle is thick. Just think about, you know, working out in the gym. You know, you got more muscle to depolarize, so the voltage gets higher, and you also get a type of intraventricular conduction delay that's mild. It's more than abnormal. It's more than normal, but not as bad as a bundle branch block typically. Notice also too, you know, we had talked about axis. With the axis here, notice is going away from the inferior leads, okay? And that's because of the voltage. So this is thick, this muscle is thick, more muscle out here, makes the vector swing up like this, okay, away from 2, 3, and F, generating negative complexes, okay, and towards L and 1, giving you positive complexes. So this is a typical classic EKG of LVH. I have voltage criteria, multiple voltage criteria. I have a left axis deviation, okay, and I have an intraventricular conduction delay. And lastly, this will be important when we talk about ischemia. A good rule of thumb when we're going to be talking about ischemia, on the 12-lead EKG, in the limb leads and in the precordial leads, if the QRS goes up, the T wave ought to be up. And here we see clearly the QRS is up, the T wave is down. QRS is up, T wave is down. And so is the J point, or the ST segment. Now, we'll be getting into this when we talk about ischemia, but that's the J point where the S wave meets the ST segment, and that goes into the T wave. this J point should be equal to the PR interval like we see here. That's a J point that looks normal, okay? Versus this J point. So this is a secondary repolarization change. This is not due to ischemia. It's due to the LVH that we see, okay? So again, to reiterate the point, and let's look at our criteria. 5 criteria, folks. 3 in the limb leads, 2, the last 2 in the precordial leads, for this very reason. Notice how on this EKG that you can see changes on one side of the EKG. This is comparing. Here, look at AVL, no voltage at all. All the changes of repolars of LVH are in the precordial leads, okay? And you don't see anything of LVH in the limb leads. So you gotta, that's why we use criteria for both. Notice this has LVH, it has repolarization changes that we were talking about. And you typically see those in the leads where you see the voltage, okay? But you can see them in other leads as well, but they tend to be seen in the precordial leads, but they can be seen like in AVL as well, all right? All right, so let's talk about RVH.
What you looking for?
Oh, this. So RVH is RV. Okay. Remember, we always go back to the same schematics. This is so we don't have to memorize anything. All we have to remember is where our leads are in relation to our underlying cardiac structure. Sternum, spine, septum kind of lines up. V1 and V2, right sternal border, left sternal border, going around to the more and more of the LV apex. There's the RV. The RV is basically under the sternum. All right. So LVH, when the left ventricle hypertrophied, what did it do? It got thicker, okay, and it expanded, okay. All right, giving you a lot of voltage, okay. And you see a lot of that in the precordial leads. It also could expand in this plane this way, and you saw changes in AVL and 1, okay? So we can understand that these are leftward leads. But now we're talking about RVH, so we have to be talking about rightward leads. And the rightward leads, what are the rightward leads on the EKG? On the precordial leads, it's V1 to lesser degree V2. Because by the time you get to V2, you're really over quite a bit of the septum. That's really a septal lead. So V1. So RVH, so, you know, you can envision, just general concept here is the left ventricle is free to roam, if you will. It hypertrophies, it has room to go. They're just long. But look at the RV. The RV, for the RV to enlarge, what's it going to do when it enlarges? Now, you can talk about enlargement acutely, or you can talk like in a pulmonary embolus, or you can talk about enlargement due to like constant pressure overload. At any rate, if it's going to get big, for lack of a better word, if it's going to hypertrophy, well, where is it going to go? Is it going to push the sternum out of the way? No. Is it going to push the left ventricle out of the way? No. Is it going to push the esophagus and the spine out of the way? No. It can only go one way. It's going to go that way, towards the right. That would mean towards V1, okay? In another plane, that would mean, think about the axis, it would be swinging around like this. So you would get forces towards 3 in R and towards V1. That's what you would anticipate. Okay, and now this is what we do. We just think to ourselves, what would we guess? Knowing this, what would we guess would we see with RVH? Okay, so this is what we see. Let us look. At a normal EKG, refresh our memory. And here we are in a normal EKG. V1 and V2 have very small R waves. Why? Because they're not over much of the left ventricle. They're really over just at best a little bit of the septum and the right ventricle. That's why you have a little bitty R wave, because all the vector, if you summed up all the vector and where's all the muscle mass, it's over this way. So so you're really going away. The left ventricle dwarfs the right ventricle in size and mass, and so all the voltage is going that way. Remember, the height of the R wave is related to the mass and interline interference, like fat or air, and the direction is the vector has sums up versus where your leads are. So typically we have a small R wave like we see here in V1 and V2. That's because the forces are going where? The forces are going left, like that, okay? That's where all the muscle is. But now we're talking about a situation where this gets big, okay? And relatively, it changes the ratio, the typical ratio between the two. As it expands, it changes the axis because now there's more muscle mass that way, okay? And because of the location, because that swings towards V1, we could expect more prominent anterior forces. This is a normal EKG. And now here we look at V1 and V2. This is nothing but a big R wave in V1 and a big one in V2, okay? That's because you're going right at V1, okay? You have a lot of muscle mass there. Also notice on this EKG, look what AVR looks like. It looks almost biphasic, doesn't it? That is, there's a negative initial component, so it's not all up, it's not all down like it should be. Well, biphasic, remember, what's that mean your vector is? That means you're at 90 degrees to that lead AVR. Here is AVR, all right? So my vector has to be at 90 degrees, either pointing that way or pointing that way to AVR. It's biphasic. So how could we tell which way it's pointing? We would look at limb lead 3, big R wave. So I'm pointing right here. So I have a right axis deviation then. I'm past 90 degrees, okay? So it all comes together. Might be better to see on this EKG, to illustrate the point. Big prominent R wave here, okay? Big prominent R wave here, isoelectric to AVR, and then a predominant, notice between 2, 3, and F, we have the highest R wave, most R wave is in limb lead 3. That means the vector is pointing at it. So I have a right axis deviation and rightward anterior forces. All right. Now there are some criteria which that I've listed here for you. You look for right axis deviation, a dominant R wave in V1 greater than 7 millimeters, okay? Or if it's not greater than 7 millimeters, if the R wave is greater than the S wave, okay? And then likewise, you would see a reciprocal change over here would be a dominant S wave in V5 or 6 with a small little R wave. So why would that be? Why would everything look small in V5 and V6? Because you're not going towards the left ventricle anymore. You're going away from it. You're going rightward. So you would expect to see negative looking complexes in V5 and V6. Notice also that in the leads where you see the voltage, you can see remember how in LVH we saw a strain pattern, the repolarization changes in the left leads? Well, notice here in the lead where we see the voltage for RVH, we see similar secondary changes. There's my J point, it's depressed, it goes into ST segment and inverted T wave. That's this LVH, this is RVH with a strain pattern. Okay, so now we're going to talk about atrial enlargement. Notice when we're talking about enlargement, especially when you're talking about atria, it doesn't necessarily mean that it's an anatomic enlargement. Okay, it actually can be a pressure deal. So you can get those changes if you see an acutely elevated left atrial pressure, etc. Typically, that's also goes hand in hand with structural enlargement, but not necessarily. Okay, and we're back to memorizing. All right. So just remember something here. You're going to look at 2 leads. And that's going to be important when we talk about rhythms, supraventricular rhythms. You know, remember when we were determining whether we had sinus rhythm or not, we looked where? We looked at limb lead 2. So limb lead 2 is the best lead looking at atrial stuff. And notice we look at it for either RAE or LAE. Okay, but also, and we're going to see this when we talk about arrhythmias, V1 is also a good look at the atria. So both leads. Okay, so if we look at this, what do we see? Right atrial enlargement, we talk about height greater than 2.5 millimeters tall from the baseline to the peak in limb lead 2. And in V1, also tall, greater than 1 small box. When we talk about left atrial enlargement, we talk about width. Greater than 3 small boxes wide, may or may not have this bifid hump. And in V1, greater than 1 small box, okay, down. Right atrial enlargement, okay, both looking at 2 in V1. Right atrial enlargement tall, left atrial enlargement wide. And what does that look like, let's say on an EKG? All right. On this EKG, what do we notice? We notice that, notice how on a standard EKG, you know, this is what a P wave looks like in V1. That's what a P wave looks like in 2. Notice it's not wide. It's not even maybe a small box wide. Not negative at all. And notice on this EKG, here's a large box. So that's a small box. This is like 2 or 3 small boxes wide and pointing down. Okay? You don't have to have both. You can have just one of them. So that's left atrial enlargement. And let's see. It's hard to, okay, and so here we see, for looking at the left atrial enlargement, is it greater than 3 small boxes? It's right at about 3 small boxes wide. But it doesn't matter because you made the diagnosis here, okay? And then for right atrial enlargement, remember right atrial enlargement is not about width, it's about height. And what gets your attention, if this was what a normal P wave typically looks like in limb lead 2, as soon as you look at limb lead 2 here, look at that, look at the height of that. And you just measure it with your calipers from the baseline, okay? And it's obviously tall, all right? So it's tall and peaked, so that's right atrial enlargement. So in our scheme, let's move on. Lastly here, we're talking about ischemia and infarction. Remember, you know, obviously, you know, this would come first. If you're in the emergency room and you're admitting somebody with an acute coronary syndrome or something, you know, you might do that real fast, but you're gonna go to this step, okay? You have to be practical. So ischemia and infarction. So this slide is gonna state the obvious. When we talk about ischemia or infarction, we're talking about either Q waves, ST segment depression, or we're talking about ST segment elevation. All right? So Q waves are the little small thing, the first initial negative component of the QRS. The ST segment comes off after the QRS at the J point. The J point ought to line up pretty much on the PR interval. Remember the other baselines, when we talked about QT and everything, it was the TP. For ST segment elevation and depression, it's the PR interval. I can't say that enough. You have to know what your comparison is. So we're talking about either this Q wave, ST segment being down or up or down, okay? And the T waves either pointing in the right direction or an opposite direction. Remember, limb leads, precordial leads, if the QRS is up, the T wave should go in the same direction. Okay, that having been said, for all those that we just mentioned that we're going to analyze for infarction or ischemia, there are normal and abnormal reasons for there to be findings. Okay, so, and I bring this up for a point because if you go ask and I do this when I'm on wards, I'll ask everybody in the room, so what do you think about Q waves? And they always would say it means scar, it means old infarction. No, Q waves can actually be normal. ST segment depression or T wave inversion, well, they can be normal depending on what the underlying issue is, underlying cardiac issue is. For example, we just finished with LVH, right? And we said we have all this voltage, and look at the ST segment. The T wave is not pointing up where it should, it's pointing, the ST segment's down, T wave pointing down, T wave pointing down, ST segment down. Okay, so that is abnormal, but does that mean ischemia? No, this happens to be a normal change due to the LVH. Just like you had an abnormality in depolarization, that is the hypertrophy, that gave you a secondary change in repolarization. So that doesn't get an ischemic read, okay? So we have to now, therefore, spend the rest of this time discussing how to determine what is normal versus abnormal for Q waves, ST segments, and STs down or STs up, okay? Talk about Q waves. Q waves, by definition, are abnormal if they're greater than 40 milliseconds, that's one small box, or greater than 25% of the magnitude of the QRS complex, okay? And they have to be present in at least two contiguous leads. That is, two contiguous leads within an anatomic area. So I suppose we need to back up and say, what exactly do you mean by that? When we're looking at a standard EKG, we're going to be talking about leads versus surface structure. The inferior leads are 2, 3, and F. 2, 3, F. Lateral leads L and 1. L and 1. Excuse me. The septal leads are V1 and V2. Notice they straddle the sternum. They're looking at the septum. Anterior leads come around here. And then when you get to V5 and V6, and there's a little bit of overlap here at V4, you're talking lateral leads. Okay? Septal, V1 and V2. Anterior to V4, V4 to V6, lateral. Inferior, 2, 3F, L and 1. Okay? Contiguous leads would mean 3 and F are contiguous because they're next to each other on the EKG and within the right coronary artery. So these areas correlate with different arteries typically. This would be the right coronary artery. This would be the diagonal. Anterior and lateral, all of these you can imagine would be the left anterior descending. That's how this goes, okay? So we're able to label these inferior, lateral, septal, anteroseptal, lateral, okay? Q waves, they can mean scar, not necessarily. They have to be abnormal. They have to look like this. They have to be more than 25% of the height of the R. So you just measure the Q compared to the R, that's all. If it's less than 25%, it doesn't mean anything. And you compare the width. So this is minuscule. It's short and it's very narrow, less than one large box. Here we see this is as deep as the R wave is tall. And if you could measure that, it would be wide. So that's pathologic change. Okay, that's an abnormal Q wave. Now, do Q waves always mean scar? No, they don't. And this is a topic for another day, but in an acute setting, Q waves can occur because the myocardium just goes electrically silent. So in the setting of someone with active chest pain, and ST segments up, that is having an acute event, having an acute myocardial infarction, you can get a Q wave and it does not mean scar. That topic is important. That's an important thing to know because revascularization, reperfusion is the therapy of choice. So you wouldn't want a Q wave to exclude them from reperfusion therapy. Okay. Now let's talk about ST segment depression and T wave inversion, which we've talked about a little bit before. Remember, the norm is in the limb leads and precordial leads, the T wave should go the way of the R. All right. An inverted T wave, if it doesn't, it could mean ischemia, or it could be a normal secondary change like we saw with LVH. Here we see the big voltage. Here we see the STs down. That doesn't mean ischemia. That's just a secondary change. All right. How do we tell the difference? Okay. Well, first of all, our refresher memory, the PR interval is our comparison point. That's our J point. Some people, this is in here because some people, the purists say you have to go out 60 seconds before you're looking at your ST segment. You don't really have to do that. Okay, I just put this just so we would be complete. I just look at the J point right there. Okay, so again, we're looking at a mount. Okay, it has to be deep and it has to be in contiguous leads. All right, so that's what we're looking for. And remember, it tells you ST segment depression or T wave inversion. It could be anything. If it's not due to a secondary change, if it's a primary change from an intracoronary event, it could be a non-STEMI, it could be a STEMI, okay, depending if it's up or down, or it could be angina. Remember, your troponin tells you the difference, okay, between the EKG can't tell you that. You need a troponin to check and see if you have myocardial injury. All right. We look at morphology and degree, and this slide is a good slide in that regard. B and C is what you look for. Here's my J point, there's my PR interval. My J point is down, and it's pointing down, or it's horizontal. A, upsloping, is nonspecific. That doesn't get the diagnosis. Down or horizontal, okay, in two contiguous leads greater than 0.5 millimeters at the J point. Okay, remember a millimeter is what? A small box. Okay. The deeper the depression, the worse the prognosis, and the more leads involved, the worse the prognosis. Okay, so what do we look for? PR interval, compare your J point, and then look at your ST segment from the J point. It's either downsloping or horizontal, not upsloping. Okay, two contiguous leads, 0.5 millimeters. Now, how do we differentiate normal from abnormal? What's the issue? The issue is you're trying to figure out, is this ischemia, that is an intracoronary disaster, or is it due to another abnormality in the EKG, a secondary, what we would call a secondary change, okay? Secondary changes occur in LVH, left bundle branch, and right bundle branch, okay? Notice we have a lot of voltage and we have the secondary change. The J point is down just a little bit. The ST segment is definitely depressed. Notice in left bundle branch block, we're looking at a leftward lead, V6. You notice how wide the QRS is. And notice in the lead where we have the change in depolarization, we have a secondary change in repolarization. The ST segment's down. Same with right bundle branch block. In right bundle branch block, the characteristic finding is of rabbit ears, one rabbit ear, second rabbit ear, is in V1. And notice in that lead where we have the abnormality in depolarization that gives us the diagnosis of right bundle, we see secondary changes. Okay, so the QRS actually tells you whether the ST segment is abnormal or normal, if it's a primary change or a secondary change. So you look for LVH or one of the bundle branches, okay? Let's illustrate that maybe. I hope this is good enough to see. Let's look at left bundle branch block. Here we see a wide QRS. Remember, left bundle branch block, we look at the left leads. The left leads are what? The left leads are 1 or L and V6. 1, L, 6. We see a wide, lumpy QRS, very wide. and secondary ST segment changes. Okay, notice these are asymmetrical. All right. LVH, let's look at LVH, where we have all this voltage. Here's my R wave. See how this is a double dense, it goes up and then makes a really dark double dense thing and then it stops. So that's my R wave. All right, look at that deep S wave. And in the lead where I have all the voltage, notice I have this asymmetric depression. J point is down under the PR, downsloping ST, T. This one is ischemia. Notice in ischemia, the QRS looks normal. Notice we have T-wave inversion. The T-wave is pointed the opposite direction from where it should be, okay? And notice how this is symmetrical. Symmetrical, see that? If I took a straight edge and would draw, I would make a perfect V. Here, I wouldn't. That is a gradual slope to a quick upstroke. So the secondary changes tend to look like a reverse check mark. Ischemia tends to be symmetrical. So we're going to talk about ST segment elevation now. This is an injury pattern, all right? ST segment elevation infarction, that's what we're after. Now, along with what we've talked about before, the notion that there are normal and abnormal reasons to have ST segment elevation, I would like to point out by looking, before we start here, by looking at a normal EKG. We note that if you look carefully here, and I don't know, I hope this shows up adequately for you. Remember, when we're talking about ST segment elevation, we're talking about the J point, where the ST segment comes off the QRS. And we're comparing that to our baseline, which, as we see here, is the PR interval. If you recall, other baselines that we talk about, for anything else except for injury, the baseline is between the T and the P. Here, we compare the J point to the PR interval. Just like we do with ST segment depression, we do it for ST segment elevation. And if you notice in a normal tracing, as we see here, if you look very carefully, my J point is right here. How do we know where it is on this EKG? You just follow the S wave up and notice that that's a nice, clean, single slope. And where there's a transition, that's the J point. So my J point is right there. If you compare the J point to my PR interval, you notice that it's up, just a smidge above it. Nevertheless, it's elevated, okay? Maybe a half a small box, not even a small box. We see the same thing here. There's my J point, and notice it's almost a small box above my PR. So this just illustrates a point that in a normal tracing in these leads, okay, most notably in the septal leads, ST segment, J point elevation, therefore ST segment elevation that is mild, and here barely noticeable, does exist, okay? So we have to differentiate normal from AB normal, all right? First of all, this is one of the few things you do have to memorize, I'm sorry. This is in a conduction that's normal. There's no LVH, bundle branch block, or paced rhythms, which can make the ST segments go way up in the septal leads. Yeah. For example, here's LVH, and now here's our J point. Okay, let's redo that. S comes up, and where you see the transition, that's the J point. We compare that to the PR interval. Here we see it's elevated 3-4 millimeters. So with LVH, left bundle branch block, not right, and in paced rhythms, you can see profound ST segment elevation in the precordial leads, in the septal leads. That's V2, V3. Therefore, we have criteria. In the absence of this, what makes normal versus abnormal. In males, there are two criteria with a set point at 40 years of age. In people that are older, 2 millimeters, and people that are younger, 2.5 millimeters. All that means is ST segment elevation is common in younger people, and so you give it a little leeway, 0.5 millimeter, okay? In females, it's 1.5 millimeters. That's in V2 and V3. All the other leads, it's 1 millimeter, And these leads, V3, V4, V7 through V9, these are reverse leads. This is reverse lead V3, reverse lead V4. And what those leads are, if you look at it, if you look at our schematic here, here are our normal lead placements, V1, V2. Here's to orient us, there's our sternum. The RV and the septum are pretty much retrosternal, okay? Then the LV is obviously in the left thorax if you don't have dextrocardia. Okay, but there are leads looking different places in the heart. We made this point before. Knowing lead placement and underlying structure is important. If there, you can just imagine if there is a right ventricular infarction, or you wanted to see if the right ventricle had taken a hit, you would want right-sided leads. In other words, these leads probably wouldn't help you very much. These leads certainly would, but notice they are still over, especially V2, a good part of the LV. So with reverse leads, you just put the leads on this side of the chest. That way they're looking right at the RV. Okay, that's reverse V3, V4, okay? All right, looking for anti-infarction. The other leads, posterior leads, 7 through 9, are just a continuation of 6. We just put them posteriorly infrascapular, looking at directly at the posterior surface of the heart. Okay? So that's what it is. Here we go. V2 through V3, in older males, 2 millimeters, under 40, 2.5, females, 1.5. Age is not an issue there. All other leads, it's 1 millimeter, let's say like AVL, 2, 3F, and it's a 0.5 millimeter in these leads, okay? Measured from the PR segment, J point, where either your R wave or your S wave comes down into the ST, and there's an abrupt transition. Compare that versus that. That's what we're talking about. All right, so this is what happens when you're having the real deal. It's time related. You think about reperfusion therapy for infarction. This is what's going on. This box here, if you notice, this box is at 0 hour. Okay, this is the initial insult. It occurs in the first few minutes. The T wave becomes hyperacute. Okay. Now let's compare this. Let's look at, again, T waves. If we look at our T waves here, these are normal T waves. This is normal EKG. And notice these T waves, if I drew a slope here along that limb of the T and that limb, it would be asymmetrical. Okay? Same here. Asymmetrical. Okay? And notice it was not very tall. That is, compared to the R wave, it's certainly less than 50% or around 50% here. Asymmetrical and not high amplitude. Notice this is totally different. This is high amplitude. It's higher, hyperacute in voltage compared to the R wave. And now it's become symmetrical. Okay, this occurs in the first few minutes. This occurs while the patient's still watching television and in denial, thinking they might have reflux. We don't see this very often, except we do see it in people who develop a STEMI that are inpatients, which is pretty unusual, but it can occur. So we don't see this often. You have to almost have been standing outside the emergency room and then present at the immediate onset of chest pain to find this. And this is typically then what we see. The T wave flares, okay, hyperacute, symmetrical. And then the J point, okay, R comes down to there's the T, abrupt transition, there's my J point, there's my PR. Then after this becomes hyperacute and symmetrical, then the J point comes up, ST segment elevation, STEMI. All right. Then in the next few hours, okay, as the infarct rages on, the J point stays elevated, you can develop Q waves. The important point here is that those Q waves, in the presence of ongoing chest pain and ST segments elevation, do not imply completed infarction. So you still want to reperfuse the patient in this time frame as long as the ST segments are up. Okay. After several days, what happens? Now this infarction. This is an untreated infarction. This is the natural history of what old terminology, transmural infarction, ST segment elevation infarction. Now, over time, the Q wave gets deeper and the T wave inverts. And what it does, it's kind of cool. The T wave actually becomes biphasic. So up, there's a component that's up, and then it goes into a downward component. Days later, the infarct is now completed. The Q wave remains. The Q wave here is different than the Q wave here. The Q wave after days implies completed infarction, but hyperacutely in the setting of STs up in the correct history, it just implies the fact that the acute ischemia has rendered the myocardium electrically silent, and it can't conduct it doesn't get an initial vector, okay? And it gives a Q wave. So these Q waves are different. The scar, the Q wave denoting old scar, remember, it has to be deep and it has to be greater than 1 box wide to be significant. It starts at days later and can last indeterminately. Then what happens is the T wave just flips, inverts totally, and weeks, months later, you're left with this. The T wave becomes normal, you still have an R wave, and then you have a Q wave. So that's the time frame of a STEMI. And so I want to remind everybody too, as we move on here, that there is, with everything that we're mentioning in this initial presentation, we're going to have a blowout detailed presentation on it in the differential, so we'll be able to it's like peeling an onion. We'll be able to look at it in more detail and understand it better. This is just an overview, okay? So the theme here in this packet is, identifying, separating normal from abnormal, and therefore we have to discuss about ST segment elevation, normal, and then also abnormal, but not ST segment elevation infarction. Okay, so with ST segment elevation, it can be normal, as we saw on a 12-lead EKG. It was very mild, remember, just in the septal leads. Okay, it can be a STEMI, okay, abnormal. It can be another benign normal variant, different from a normal EKG, nevertheless benign in diagnosis, and then another one that is a pathologic diagnosis. So let's talk about what those are. Normal from abnormal ST segment elevation. We look at three things, folks, and this is, you got to kind of get the concept. And just remember, the EKG can only show you so many things, right? It can only show you size, morphology, geography. That is what leads. So when we talk about ST segment elevation, and what we're trying to do is separate normal and other abnormal causes from ST segment elevation infarction. This is, STEMI is, this is an element of heart disease, and heart disease is the #1 killer in the country. So we're always looking to make sure we're not going to miss this. So we're going to look at morphology. That is the shape of the ST segment elevation. Here we can clearly see that it's profound and up. We talk about geography, distribution, that is what leads are involved. We want to know, is it focal, just to a few leads like 2,3F, or just the anterior leads, or is it everywhere and diffuse, like we see here? And then degree, how many millimeters? So we want to know, what's it look like, what leads are involved, focal or diffuse, and degree. Is it mild or is it profound? That's it, okay? So we use the words, let's start with morphology. We use the words concave and convex. Concave, convex. I don't know. A lot of people have problem remembering which is which. So what you can do is you can think of it as a smiley face or a frowny face. See how the ST segment is coved up, it bows outward, and here in concave, it's scooped like a U. like a smile, like a frown. Why is that important? Because the smiley face is smiley, think happy, think benign causes of ST segment elevation. And then frowny face, the bad kind of ST segment elevation, that is what we've been talking about here. See the frowny face there. All right. So now we move on to geography, and we're talking about focal versus diffuse. The concept here, folks, is a lot what we've been talking about before. You have to know leads and where they are in relation to the surface of the heart. We've seen this diagram a bazillion times. I'm sorry, I know you want to throw up. V1 through V6, here we go across the precordium, different parts of the ventricle. V1 and V2, we made the point, are septal leads, anterior leads, and then the lateral leads, V5 and V6. Why did we go out of our way to note that? That's because these different areas of myocardium that we are labeling septal, anterior, and lateral are subserved by different coronary arteries. Okay, so here we see the left anterior, for example, artery, okay, going across the anterior surface, gives off branches, okay, laterally, the lateral precordial leads, all right? Here we see the right coronary artery feeding the right ventricle, okay? Inferior leads like that. So that's the concept, okay? So it's focal. In other words, I can look, focal on the EKG means that you're looking in a distribution that I can name. I can say it's inferior, 2-3F, it's septal, it's anterior, it's lateral. It's not diffuse. So on the 12 lead, it looks like this. And this EKG is just a blown up version of this one. Here we can clearly see that the ST segment, here we go, there's our PR interval. The J point is up over a millimeter. Remember our criteria. This is several millimeters. Each small box is a millimeter. Several millimeters. Frowny face, morphology. Okay. Convex. Okay. And in leads 2-3F. Okay. Not elevated in 1. Not elevated in V4, V5, V6. Okay. We do see ST segment depression, however. Okay. In leads that face opposite of these leads. Those are called reciprocal changes. So here we go, inferior. We can say this is inferior. All right, okay. That's versus this EKG, okay, which we look at, and the first thing we notice is what? It's almost like you have to really look hard to see if there's ST segment elevation, by means of comparison to this EKG where it jumps out, okay? So that gets back to degree. It's not subtle. At first it might be, but over a few minutes it won't be. So here we have PR, and there is my J point. J point is just maybe 1.5 millimeters, you know, versus several millimeters here. And we see it elevated in 2. We see it there. There's the PR. It's elevated in 3. There it is. Go straight over. It's elevated about 1 millimeter in F. So it's also inferior, but is it elsewhere? Yes, V6. There's my PR. There's my J point, about 1 millimeter. There's my J point in V5. So now we're now we're in the lateral leads. Okay, and we see it elevated in 1, all right, and we see minor, there's the PR right there, minor elevation in V4, okay, so we would have to call this diffuse, all right. Also notice the difference in morphology. This is a smiley face, okay? Smiley face versus frowny face, convex versus concave. We got with morphology we discussed. We got the geography, inferior versus diffuse. And we have degree, profound, multiple millimeters versus mild. Okay. That having been said, when we have diffuse mild ST segment elevation, we think of two diagnoses immediately. We think of pericarditis and we think of benign early repolarization, BER, which eventually in your lifetime will be proven to be a misnomer. Right now it's thought to be fairly benign, but as we do more work with channelopathies, we start to understand that there can be malignant forms of benign early repol, but most of them are not, so it still retains that nomenclature, okay? So now we have to discuss about how do we determine, the difference between pericarditis and benign early repol. Remember, the initial step, just to be totally redundant here, was to make sure that we weren't missing a STEMI. Okay, now we're trying to differentiate between pericarditis and benign early repolarization. So here's a 12 lead, and we look at this 12 lead. The chief complaint is chest pain. And that's all the information you got. And we look at the 12 lead. So being chest pain, we're going to be looking for ST segment depression, ST segment elevation. We distinctly don't see ST segment depression here. The T waves are all up. So we have to be talking about ST segment elevation to look for. And we distinctly do not see a tombstone, and we don't see it focal, and we don't see anything profound. In fact, all our ST segments are concave. All right. And if we look at the J point, comparing to the PR, we see mild ST segment elevation. The J point is mildly elevated diffusely, mildly, and morphologically concave. All right? But there is an abnormality on this EKG that gives us an idea about what's going on. Here's a normal 12 lead. And let's just get a feel for the normal 12 lead again. Here my J point is pretty much equal with the PR throughout. The QRS, notice, looks nice and neat and discrete. Goes up cleanly, nice clean spike, comes down to an S wave, boom. Okay, uniform and nice. All right, when we look at this QRS, what do we notice? My eyes jump here to V4. It goes up, it comes down, and there's this notch. See the same thing in V5, same thing in V6. Same thing right there in 3. Same thing there in AVF. Same thing there in limb lead 2. A suggestion of the same in 1. All right. So that notch gives you a clue to what the diagnosis is, which would be benign early repolarization. Okay. So again, the morphology is concave, diffuse, mild, and that notch. Now, the hallmark of the next one, it would be PR segment. Next diagnosis would be PR segment depression. Here, the chief complaint is also chest pain. Here, we notice that the patient is tachycardic. It gives you an idea that there's something might be wrong. We immediately, based on the history, we get the history that perhaps it was positional. The patient gets relief with sitting forward, and the kind of pain was sharp and made worse with breathing. It makes us think pericarditis, so we're going to look for pericarditis. So we see the J point compared to the PR is definitely elevated to 3, F, 6, 5, V4, okay, 1, all right. It's concave, it's mild. We don't see that notch on the back of the QRS that we saw with benign early repole, but instead, what do we see? The PR segment is sloping down and is depressed. Okay? And that makes you think pericarditis. Okay? It pretty much gives you the diagnosis. Now, notice the difference between these two, and I'm going to give you something that you can sink your teeth into a little bit better. Here is early repolarization. Okay, the patient isn't tachycardic, implying that they're comfortable. We see mild concave ST segment elevation with a J point elevation. Notice when we look at this EKG, early repole versus pericarditis, notice that the T wave looks relatively robust in early repole. By comparison, when we look at the P wave, the T wave, in pericarditis, it seems subdued in relation to the QRS. In fact, it seems quite low. We can use this then to tell us it's that ratio that tells us, is it early repole or pericarditis. In early repolarization, BER, you can take the height of the T wave, illustrated here, okay, versus the height of the ST segment, okay, and you make a ratio. And ST, the height of the ST segment, compared to the T wave, less than 0.25 is consistent with BER, okay? So a low ratio like that would mean that the T wave is relatively tall compared to the ST segment elevation, where in pericarditis, it's greater than 0.25, and we see that the T wave looks relatively subdued, and we see that the PR segment here is sloped down, and we don't see that there.